So, hello students, hope you all done your INICET exam in a great. Okay, I am Dr. SJK. I'm going to discuss ENT INICET recall questions for the November 2022 session. Okay, first ENT and overall the entire questions that has been asked in INICET, they are back. Who? AIMS. Last two INICET exams were not the actual INICET exams. They were almost similar to NEET exam. But this INICET was a ditto of previous AIMS questions. So AIMS is back. Okay, INICET is back. Why I am doing this? Because the questions will be very conceptual, very tough to answer. Unless until you know every nook and corner of your particular subject, you can't answer that particular question from that particular topic. All right. So as ENT is concerned, ENT again the otology, rhinology, laryngology part. Otology had more questions compared to other two parts. That will be the usual trend. Okay. First, we'll start with the question. A 50 years old female presented with hard of hearing, and she had following audiogram pattern. What will be the Rinne and Bieber's test? Okay. Now, this is the audiogram that would have been asked as told by some of our students. See here, right for red, blue. So red for right side, blue for left side. First, so as you could see with primary inspection, this right seems to be normal, whereas this left, see here, this is the 25 decibel mark. The left seems to be having hearing loss. So first, the patient is having left-sided hearing loss. Left-sided hearing loss. Okay. After that, what we should analyze is what hearing loss is this. See here, this is a continuous line. This are the broken lines. So when left side is concerned, the bone conduction is normal. The air conduction is abnormal. Okay. In that case, this audiogram is depictive of left conductive hearing loss. Left conductive hearing loss. Now look, we know what the diagnosis actually. Now we have to sort out the tuning fork test for this particular diagnosis. We first study about the tuning fork test. See, in tuning fork test, see this table is taken from Dhingra textbook. Renne means normal and sensory loss. It will be air conduction better than bone conduction, which is Renne positive. All right. If it is Weber's, there will be lateralization of the sound to the affected ear in case of conductive loss, better ear in case of sensory neural hearing loss. All right. Now, in case of ABC and Schwabach, these two tests are exclusive for sensory neural hearing loss. Sensory neural hearing loss. Now, you look, Rinne, if it is normal or sensory loss, it is Rinne positive, which is air conduction better than bone conduction. If it is conductive loss, bone conduction better than air conduction, we call it as Rinne negative. All right. Weber's lateralization should be observed. Now we are having left-sided conductive hearing loss. Okay. In this case, left side Rinne should be negative. Then Weber's should be lateralized to the top left side. Okay, fine. So what will be the other side Rinne? So if left is the conductive hearing loss, right should be Rinne positive. Right should be RNA positive. Now you should find out left side RNA negative and right side RNA positive. Left RNA negative. See here. Left RNA negative. Weber's lateralized to right. Okay. See in this audiogram, considering right side is normal, left side is abnormal, which is having left-sided conductive hearing loss. We are having left-sided RNA, okay, and Weber should be lateralized to the left side. So this is not the option. Okay, okay, fine. Other options all are RNA right side positive or left side positive. So RNA left side should be negative. Again, this is not the option. Right side RNA positive, again these two could be the options, but Weber lateralized to affected side or better side. It should be lateralized to the affected side. Alright, so it is right RNA positive, it is correct. Weber lateralized to the affected side, which is left side. This is the correct answer. Clear? See here, left side RNA negative due to conductive loss, lateralized to the left side. That is the correct answer. So the option for this particular question is C, right RNA positive one, Weber lateralized to left. All right. See here, this is again a depiction of, this is sensory loss. No airborne gap less than 10 decibel. This is conductive loss. Airborne gap more than 10 decibel. This is mixed loss. Airborne gap more than 10 decibel with abnormal bone conduction. Airborne gap more than 10 decibel with abnormal bone conduction is mixed loss. So this is the revision about audiogram as well as tuning fork test. Both are done for hearing loss patients. All right. Now, an important question that has been asked from surgical point of view in otology. Correct tympanoplasty types with a description. So this is Ulstein's classification for tympanoplasty. He gave 6 types. All right. So this tympanoplasty is nothing but reconstruction of the affected middle ear. Reconstruction of the affected middle ear structures following infection like CSOM or COM. All right. Now look, the options, the 4A as well as other set is given. Now we should match the things. Okay. So first we'll learn the description about individual tympanoplasties. Then we can come back to the question. So we are having malleus, incus, and stapes. If tympanic membrane alone gone, we are doing tympanic membrane reconstruction. It is called myringoplasty or type 1 tympanoplasty. Okay. Now, if TM is gone and malleus is gone, we are reconstructing TM as well as malleus. It is type 2 tympanoplasty. Again, type 3 is TM gone, malleus gone, incus also gone. So we are reconstructing TM, malleus, and incus. Okay, all these structures we are reconstructing. Okay, this is type 3. Type 4 is TM gone, malleus gone, incus gone, stapes suprastructure also gone. So we are going to reconstruct the malleus incus stapes procedure together with tympanic membrane. This is type 4 tympanoplasty. Now you look, type 5 is TM gone, malleus gone, incus gone, stapes procedure gone. In addition to that, we are having foot plate fixation. So though foot plate is there, that foot plate is non-functional due to fixation of stapes foot plate, as we could see in some cases like otosclerosis. Okay. Now, though there is some foot plate that is available, see here, this is foot plate, this is oval window, this is round window, this is the connecting structure between these structures. Here we are having lateral semicircular canal. This is oval window, this is round window. All right. See, though there is sound that could reach the oval window, okay, sound that could reach the oval window, it is due to the fixation of the stapes, it is not going further. It is not going further. As it is not going further, the sound can't be effectively conducted to the hair cells. In that case, what we are doing now, instead of making the sound to pass through the oval window through the foot plate of stapes, we are creating another surgical window over the lateral semicircular canal. Like this is called fenestration procedure. Okay, fenestration procedure, where the sound will travel through the fenestration that we create, and it will reach to the perilymph, and it will reach the hair cells somehow. Okay, so it is not a drastic improvement that we could expect. There could be some minor improvements compared to the status of the patient. Okay, so hearing status can be improved to a certain extent when we do fenestration procedure for type 5 tympanoplasty. Okay, type 6 tympanoplasty. Okay, type 6 tympanoplasty, it is called sono inversion. Okay, here what we are doing now, we are having oval window and round window. We are spreading some fascia over the oval window. Now the round window will receive the sound, and the sound will get transmitted along the perilymph subsequently. So this is called sono inversion. Okay, in sono inversion, we are placing fascia over the oval window. Sound window will act as a conduit that receives the sound, and it will spread the sound stimulus into the inner hair cells. Okay, this is sono inversion procedure of type 6 tympanoplasty. Now we can get back to the question: what is placing the graft on the malleus, on the incus? So on the malleus is, we are just placing the graft of tympanic membrane over the malleus. So type 1 is 4. Type 2 is incus. Type 3 is stapes. Type 4 is graft over round window. Okay, fine. In type 4 procedure, we are also placing the graft over the round window to avoid the impedance phenomena. To avoid the impedance phenomena, we are doing that. Okay. All right. Okay. So type A is for 4, B is for 1, C is for 3, D is for 2. So A is the correct answer for this particular question. Clear? Now the next question, again from otology, to be precise, audiology. Okay, so this is the first time after a long gap we are having two set of INICET paper, like morning session a separate paper, evening session separate paper. As per the feedback from the students, they told that morning session a question was asked from OAE, evening session the question was asked from OAE. It was a little bit different question like that. I got feedback, so that I am giving it two modes of this question, two what to say, two versions of this particular question. Okay, so if OAE is absent, what is the next step? See, OAE is the screening test for congenital deafness. Okay, so if they ask in this manner, what they are trying to say is, if OAE is absent, what test you could use for screening the congenital deafness? Okay, what test you could use for screening the congenital deafness? The test that you could use is, see here, this audiometry should be done only after 5 years. In speech audiometry can be done after some 4 to 5 years. Okay, impedance audiometry is mainly for middle ear pathology. So you can't precisely measure the inner ear. Yes, it also measures the stapedial reflex also. So that note, if they would have given tympanometry means, we could have considered that option. Okay, but still it is not the best option. See, this test which was done previously, free field audiometry. What is free field audiometry? See, we are having a soundproof room. We are giving sound signals, normal speakers. Okay, we are just observing the behavior of the child. Okay, it can also be correlated with an audiometry called behavior observational audiometry. Behavior observational audiometry. See here, we are observing the behavior of the child, or we can observe the sound changes, the behavioral changes in response to the sound stimulus that we are giving with the help of the speakers. Okay, this could also be done in adults. Okay, in adults, OAE is done for ototoxicity and noise-induced hearing loss. Okay, so in that case is also for fitting hearing aid for such patients, we could use the free field audiometry. So the correct answer for this particular question would be free field audiometry. If most of them have told that Bera is not given in the options. Okay, so Bera is not in the option. If Bera was given, you could choose Bera. But concerning the option that was given for you, this could be the correct answer. Some are telling that the answer was multiple answers, questions like that. If OAE absent, what is the next step? Impedance audiometry, audiometry, speech audiometry, field audiometry. Choose the correct options. In this case, again we could choose free field audiometry, and also we could add impedance audiometry. Okay, so the answer is 1 and 4 for this particular question. So we are having two good tests, out of which free field should be the better test of the lot. Okay, see, free field, we are not receiving the response of the patient. That is the advantage of free field audiometry compared with the other three tests. In other three tests, the patient should say whether I am hearing the sound or not. So subject to test. Free field is a kind of subjective test, but we don't have to rely on the response given by the patient. We just have to observe the behavioral change of the patient. We could plot that, we could observe that, and we could give a report of that. Okay, this is free field audiometry. It is a better test when OAE is not there. Okay, if the option behavior observational audiometry is given, that could be the best answer. Behavior observational audiometry, that could again be the best option. Could be done till 2 years. Could be done till 2 years. Okay, so that's all about the question that has been asked. So it was quite a tough question as per feedback from the students. A 10-year-old presented with current hearing loss, oral fullness, no discharge, tympanic membrane intact, tympanogram showed D type of graph in impedance audiometry. Next step of management. See, this is a easy question that has been asked in recent times, recent INICET, recent NEET. So the answer is adenodectomy with grommet insertion. So 10 years old child. So the option is very clear. So this is glue ear or blue ear, or otherwise called serous otitis media. Otitis media with effusion. Otitis media with effusion. You could see air bubbles behind intact tympanic membrane. Air bubbles behind the intact tympanic membrane. Okay. So important investigations. See, earlier there will be eustachian tube obstruction. If you are having an eustachian tube obstruction, there will be a negative type of tympanometry graph, which is type C. Whereas after the eustachian tube obstruction, there will be fluid collection, that is serous fluid collection inside the middle ear. That will lead to a graph called B graft or flat curve. So these are important investigation points. Okay. So earlier it will be type C, later stages it will be type B. If both are given, you should choose the best answer. B is the best option, but you can't deny the fact that C can also occur in earlier stages of this otitis media of deficiency. Clear? Fine. The answer is adenodectomy grommet induction. So considering the age, this should be the best answer. So when only antibiotics, only adenectomy, only grommet are not enough for during this particular patient. Okay. Very, very important topic, repeatedly asked. Okay. Now we're done with some from the otology. Now we are entering into rhinology. See, this is again an alarming sign for future INICET aspirants. See, this type of question, this topic has never been asked. Even the senior resident, the junior resident of the ENT-PG, who is studying ENT-PG, he also would have not aware of this particular question, because this topic is not been taught. It's not an important topic. So this question is a tough question according to me, but how it has been asked was quite easy only. Okay, if you just think of it, you could have answered. So all of the following are smell perception test except. So we are having 4 different tests. Okay, smell diskettes test, INICET test, smell threshold test. Okay, first the smell diskette test is nothing but we are having 8 set of smell with diagram for that. For example, we'll give a tomato smell. The patient should plot the tomato. So 8 set of smell should be given for the patient. The patient should plot it. Okay, this is called smell diskette test. Smell diskette test. Okay, smell diskette test. Then important test. Okay, INICET. University of Pennsylvania smell identification test. Okay, so see here in INICET test, this is a gold standard test for smell disorders. All right. See, we are having 4 booklet with 10 questions each. So there is 1 mark for each question. One mark for each question. In that case, we should getting a score of maximum is 40. Okay. So if the patient is giving a score of 40 different smell will be given. See, this is the INICET chart. The chart will be having some sticker like thing. If you peel off the sticker, it will give off the smell. If the patient has good smell perception, he could tick the multiple choice question like you people. So 4 options will be given. Which smell you just smelled of? Tomato, potato, onion, right? Like that. Okay. So 4 out of 4 smells, the patient should tick mark the smell. So like this, 40 questions will be there. Out of 40 questions, how many marks the patient scores should be plotted? So if the patient answers correctly 34 to 40 questions, normosmia. Okay. If the patient has only 6 to 8 marks, it is total anosmia. You just remember these two things. If it is less than 18, this is total anosmia. 34 to 40, it is normosmia. Okay. This is the standard question because this INICET question can be asked in detail in the next science exam. So you just have a look at it. How it has been plotted. What is the inference of INICET test? You should know this. Clear? Now, so the third test is smell threshold test. Okay, smell threshold, constant exposure of particular smell over a period of time. If the patient could smell that correctly, you could plot it as smell threshold is normal. Okay, that's how this test works. Whereas the saccharine test is the correct answer, where saccharine test is a test done for identifying mucociliary clearance. Okay, identifying mucociliary clearance. That is saccharine test. Okay, we are giving some saccharine into the nasal mucosa. That mucosa will be pasted or projected over the nasal epithelium. That will in turn give the intactness of the mucociliary mechanism. Clear? So that's the first question from the rhinology. Clear? The answer is saccharine test. The next question. The marked structure opens into which of the following? See here, this is a cadaveric image. The cadaveric image, we are looking at the lateral wall of nose, which is the most important anatomical aspect of the rhinology. So we are looking at lateral wall of the nose. It is pointed to some structure over here. So first you should know what structure is this. Okay. Then you should know that structure will drain into which meatus or recess. Okay. First we look at the meatus and recess. We'll start with inferior meatus. Nasolacrimal duct opens into inferior meatus. Middle meatus will receive maxillary sinus, frontal sinus, anterior ethmoid sinus, superior meatus, posterior ethmoid sinus, sphenoethmoidal recess, sphenoid sinus. Okay, sphenoid sinus. Clear? Now look, out of these sinuses, okay, which sinus has been pointed here? It is not maxilla, it is not ethmoid, it is not ethmoid, not maxilla, it's not frontal, and the answer is sphenoid. So this is a sphenoid sinus which has been pointed at the cadaveric image. So sphenoid sinus drains into sphenoethmoidal recess. This is the correct answer for this particular question. So again and again, they are asking repeatedly the important topic. Okay, so lateral wall of nose should be very clear in every aspect. Okay, this is the sphenoid sinus opening into sphenoethmoidal recess. Okay, so this one is the superior meatus, middle meatus, inferior meatus. So the superior meatus is the very important part that you should be very clear of. All right. Now, next question from rhinology again is a patient with nasal deformity comes to the OPD. On examination, there was septal perforation. Most likely diagnosis is. The problem with this particular question is all these diseases can cause septal perforation, be it cartilaginous part or bony part. Okay. Now, I'm not sure any other diagnostic point has been given. Okay. So to be precise, any of them can cause a nasal septal perforation. How could we approach this question? If this is the exact question that has been asked, how could we approach this question? So first, the systemic diseases that could cause erosion of the bony septum and cartilaginous septum. First, we should look at this. Cartilaginous erosion is by TB or leprosy. Bony erosion is by syphilis. Both cartilaginous and bony erosion is by vaginous. So vaginous has been given, syphilis given, TB given. Okay, and again could also be NK cell lymphoma. NK cell lymphoma only cartilage. Okay, it is again cartilage or bony part. So both it could affect. It is called midline lethal granuloma, affecting the midline structures. It could be cartilaginous or bony. Midline lethal granuloma or NK cell lymphoma due to CD56 and Epstein-Barr virus infection. Clear? Now we look what answer we could choose. Based on the severity of the disease, we could choose it as NK cell lymphoma. But according to me, the one word that comes to my mind is deformity. If you think of deformity, it should be either leprosy or syphilis. If you think about the most common disease, incidence wise most common, okay, literature wise most common, if you think of that particular aspect, again TB causing perforation is not so common, but syphilis causing perforation, syphilis causing saddle nose deformity is very common. Syphilis causing saddle nose deformity is very common. Okay, so that aspect, syphilis causes saddle nose deformity. If the option would have been leprosy, means again we could consider leprosy. If it is not given, syphilis could be the correct answer according to me. See, this is purely subjective. The options can vary depending upon the question that has been given. So according to me, the only point that I hold good is nasal deformity. For syphilis, nasal deformity is very common, and incidence of syphilis very common compared to other diseases. In other diseases, B genus can occur, TB can occur, NK cell lymphoma can occur, but all these diseases will not cause nasal deformity always. Okay, very rare. In that aspect, I consider syphilis as the correct answer for this particular question. Okay, so we are done with 3 questions that has been asked from rhinology. Okay, now we can deal about the questions that has been asked from laryngology. All right, in laryngology, a patient comes to breathing difficulty, foreign body ingestion. Which of the following now would have been prevented choking by cough reflex? So a foreign body has entered into the upper respiratory tract of a patient. So the foreign body has tried evading out with the help of cough reflex. Okay, so which nerve is helping the foreign body evading out with the help of the cough reflex? Okay, so the nerve could be external branch of superior laryngeal nerve, internal branch of superior laryngeal nerve, rectal laryngeal nerve, glossopharyngeal nerve. The glossopharyngeal nerve is exclusively for pharynx, so it cannot be the correct answer. So the problem with these 3 nerves, recurrent, so nerve supply of larynx divided into superior laryngeal nerve, rectal laryngeal nerve. Rectal laryngeal nerve, first one is sensory supply below vocal cord, that is subglottic area. Motor supply all muscles of larynx except one muscle. That muscle is cricothyroid. So the cricothyroid is supplied by external branch of superior laryngeal nerve. Okay, whereas internal branch of superior laryngeal nerve will be supplying the laryngeal mucosa till vocal cord. Laryngeal mucosa till the vocal cord. In that aspect, if you consider this, so it is internal laryngeal nerve, internal branch of superior laryngeal nerve will be the correct answer for this particular question, because till the level of vocal cord, the sensory supply is by our internal branch of superior laryngeal nerve. So cough reflex will be initiated with that particular nerve. Okay, so that should be the correct answer. Clear? Next question, this foreign body question repeatedly asked in every exam. Last week also one tougher question was asked with this scenario. See here, foreign body You should be very clear in a systematic approach. First, a 2-year-old baby coming with history of breathing difficulty, cyanosis. You should observe cyanosis. Then diminished breathing on one side. Okay, mostly left side, they said. Okay. Next, immediate step of management. Okay, pa. The level of the foreign body can be assessed by the presenting symptom. Okay. See here. We are having so this one is the esophagus. This one is the airway. This one is our vocal cord. Okay. So a foreign body that is trying to come into the upper aerodigestive tract. It could be nose. It could be a nose foreign body. It could be a oral cavity foreign body. So anyway, it is coming to the oropharynx like this. See, the foreign body has entered into the oropharynx. If you see a foreign body at the nasal cavity itself, you try to remove the foreign body there itself using a instrument. If you see the oral cavity at the level of if you see the foreign body at the level of the oral cavity, you just do sweeping. Okay. So first at the level of oral cavity and nasal cavity. So nasal cavity, use an instrument, foreign body remover. Immediately. Okay. Foreign body removal immediately. If it is oral cavity, see, I am talking about infants, some 10 months old, 2 years old, all infants. So if you suspect a foreign body at the oral cavity, if you are the parent, you put the index finger over the oral cavity, you do sweeping, blind sweeping, so that the foreign body will be palpated with your index finger. You should evade out the foreign body. So this is the second step. No, sir, the foreign body has entered the oropharynx like this. This oropharynx, the foreign body, can enter into either the airway or the foot passage. Okay. So first we'll tell you the easiest thing. So while entering into the foot passage, it will first get blocked at the level of cricopharynx. So the cricopharynx is one of the constriction of the esophagus, the first constriction of the esophagus. Okay. So this foreign body coin is actually at the level of the cricopharynx. Okay. So these children, this is the first 3-step children present with no breathing difficulty, only history of foreign body. Okay, so if you see at the cricopharynx, either you put upon a laryngoscope to visualize the foreign body and remove, or you could use a rigid esophagoscope to remove the foreign body. See, the foreign body is at the level of here only. So you're going to visualize the foreign body and you're going to remove the foreign body with the help of forceps. For that, you could use a laryngoscope or you could use a rigid esophagus. Most of the oftentimes you are using rigid esophagus. Okay. Perhaps if the foreign body is not entering into the foot passage. Okay. So if it is entering into the air passage, the child will be having breathing difficulty. Once it has entered into the airway, there is no coming back. First, there will be choking, cough reflex. Both of them will be there. If you immediately see a choking episode of a children or adult, you immediately do a Heimlich maneuver. For adults. In case of children, You give chest thrust like this. Chest thrust like this. Okay, that will bring out the foreign body. See here, I'm looking at the aerodigestive tract. It has airway as well as footway. Now I am entering into the airway. Okay. If not, I could enter into the footway. So this is the trichopharynx. This is the esophagus. Okay. So if the foreign body has entered into like this, you are using either a laryngoscope or esophagoscope. If the foreign body has entered into the airway like this, there is no. If you are going to diagnose, or you should remove using the bronchoscope. Okay, in this aspect, you could use either a rigid bronchoscope or a flexible bronchoscope. See, this is a flexible bronchoscope. It could be done by a pulmonologist. Flexible bronchoscope can be inserted. It could be reached till the bronchus. Okay, you could use this. So here you can't introduce any instrument. Okay, you can't introduce any instrument like this. For that, this flexible bronchoscope most of the times is used for diagnosis and visualizing the foreign body. Okay, whereas rigid bronchoscope used for removing the foreign body. Used for removing the foreign body. I could show you how. See here. In this case, the child exactly presented with the findings as per given our question. So reduce the diminished breathing over the left side, suspected foreign body injection. Okay. See, we are inserting into the airway the rigid bronchoscope. See, we are entering into the trachea. This is carina. See, at the left side of the carina, can you see some edema on foreign body? Can you see? So this is a rigid bronchoscopy. Through the rigid bronchoscopy, we are inserting the rigid endoscope, and if we see like this, we could remove the foreign body there itself. We are having special instruments, a long instruments, rigid instruments that could remove the foreign body then and there. Okay. So flexible bronchoscope, as it is flexible, you can insert an instrument for removal, whereas rigid bronchoscope, which is done by ENT people, okay, you could remove the foreign body then and there. All right. So this is an important question. So what you should search for? See here, if it is nasal cavity, oral cavity, just history of foreign body. If it's a cricopharynx, foreign body sensation of the throat. That's all. If it's at the airway, the patient should be having choking or cough reflex. Okay. If it is at the entered into the lungs, the patient will be having abnormal breathing, reduced breathing, there will be collapse of the lungs, all sort of complications will be there. So you should immediately try to remove the foreign body as much as possible. The answer for this particular question is bronchoscopy. Okay, so we should do a rigid bronchoscopy for diagnosis. That should be the best end of management. You could take a CT chest, but that will not confirm the diagnosis. But bronchoscopy will confirm the diagnosis. Okay, so that's an important question that has been repeatedly asked in exam. Just make a note of it. Okay. Now, the question which is not purely ENT but tonsil which has been given, I just give you some details about it. The following presentation is associated with this is orange. Okay, orange patches over tonsil. Orange patches over tonsil. Okay, it's nothing but Tangiers disease. Tangiers disease, it is a cholesterol disease. There will be increased HDL level. Okay, this increased HDL level will present as some concretions of the cholesterol crystals all over the upper air digestive tract like this. Okay, so Tangiers disease. Considering other options, follicular tonsillitis, you will be having whitish patches, not orange. A beta lipoproteinemia, you will be having cholesterol, abnormal cholesterol values. Okay, abnormal cholesterol values. The patient will be having steatorrhea. patient will be having steatorrhea. Whereas protein C deficiency is nothing but related with some bleeding disorder. Okay, so see here, out of 200 questions, another question was asked like jugular foramen syndrome. Which of the structures will be affected? That question was again closely related to ENT, but another people will teach you. That's why I didn't cover that. So closely in recent exams and all, almost 10 questions are being asked from ENT. Right since the COVID period, the importance for ENT has been rising. Okay, so you should never leave any topic in ENT so that you will have a systematic approach while dealing about upper aerodigestive tract. See, larynx theory part is very minimal in ENT, but you have to combine larynx with bronchus as well as lungs anatomy and pathology while studying about pulmonology. Okay, if you study all these in same aspect, in the same systematic manner, you could answer and understand few important concepts. So in this aspect, the questions are asked. Yeah, I understand. Other than 3 or 4 questions, most of the questions are very tough. But studious people who are itching for this INICET seat, they would find it as a cakewalk. Okay. Others, you should try very hard for cracking your NEET exam. So according to me, this aims should act as a catalyst for your NEET preparation. Okay. For me, my first AIMS exam, I got around 15 to 20,000 rank only. I was very depressed. I had 2 months remaining for NEET exam. So I gave my best effort. Okay. So in that best effort, I got my seat. I got my MSc. Okay. So AIMS, INICET, you should never lose hope. You never lose heart. That will act as a catalyst for your NEET exam. Okay. You should never ever lose your hope. So you should study as much as possible. Okay, I hope it was a great session. People keep on revising, keep on correlating stuff that will help you in a great way. Thank you.